We want to welcome all of you to this webinar sponsored by the Ready Hub and also the Center for Methods in Implementation and Prevention Science. The Ready Hub is funded through the Ending the HIV Epidemic supplement program and brings together the expertise of Yale's Center for Methods in Implementation and Prevention Science and the Center for Interdisciplinary Research on AIDS. We call it the Ready Hub for short. That stands for the Rigorous, Rapid, and Relevant Evidence Adaptation and Implementation to Ending the HIV Epidemic. It's a mouthful. And so we just refer to it as the Ready Hub, and we're pleased to welcome you today. We provide technical assistance to EHE projects around the United States. We do this in collaboration with the Implementation Science Coordination, Consultation, and Collaboration Initiative, ISCI, creating opportunities to translate the local knowledge that's being developed across the country into generalizable knowledge whenever possible. The Ready Hub offers comprehensive expertise in implementation science methods, frameworks, strategies, measures, and outcomes in HIV research and design, in design and management of experimental and observational implementation science studies, data collection and sampling, quantitative, qualitative, and mixed methods analytic approaches, partnership formation, community-based participatory research, and public health ethics. Broad base of expertise. This webinar is co-sponsored, as I said before, by this Yale Center for Methods in Implementation and Prevention Science, the Yale Center for Interdisciplinary Research on AIDS, and the Implementation Science Coordination, Consultation, and Collaboration Initiative. I want to mention to you that coming up on November 3rd, we're pleased to have Laron Nelson from the Yale School of Nursing sharing his work that he's titled No Black Man Left Behind, Conundrums and Considerations for Designing a Multi-Level Hybrid HIV Implementation Efficacy Trial. And so this is an update on an ongoing project Laron is working with, and we're excited to have him sharing what's happening in that project in real time. If you'd like to know more about future Ready Hub events, please notify Christine Simon in the chat, and she will make sure that you're added to the email list. And now it's my great pleasure. I guess I should start by saying that I'm Debbie Humphreys. I'm a part of the Ready Hub. I've been working with Donna Spiegelman and Raul and Chris on the Ready Hub for 2 years now with a background in implementation science and community engaged research. And it's a pleasure to get to introduce Raul today. Raul is a recently promoted to a research scientist, which we're very congratulations on that, Raul, in biostatistics at the Center for Methods in Implementation and Prevention Science at the Yale School of Public Health. He's also the Associate Director of the Interdisciplinary Research Methods Core in Yale's Center for Interdisciplinary Research on AIDS, CIRA. His research mainly focuses on HIV, AIDS, cancer, and implementation science. He also conducts research to develop and apply causal inference methods for the evaluation of HIV prevention interventions and methods to account for exposure measurement error. So some of these complex implementation science questions that we need to develop the methods to improve our ability to handle them. He collaborates on research projects and grants in New Haven and other settings in the United States, as well as in low and middle income countries, including Mexico and Uganda. He's interested in adapting, developing, and applying interventions to increase the uptake of evidence-based interventions and practices for HIV, for cancer prevention and care, and strategies to enable their implementation. Raul provides expertise, consultations, and technical assistance on implementation science and research methods, design and analysis to affiliates of the Center for Interdisciplinary Research on AIDS, and to projects in EHE, ending the HIV epidemic priority areas through the Ready Hub. He completed a training on the Multiphase Optimization Strategy, MOST, taught by Dr. Linda Collins, the MOST developer. And we're really pleased to have him able to share his work with that strategy here today. He teaches on MOST for the course on Advanced Methods in Implementation and Prevention Science at the Yale School of Public Health. And that's a required course for all of the implementation and prevention science methods pathways for biostatistics students. And so Raul, we'll go ahead and turn it over to you. And we're pleased to welcome all of you. And again, if you have questions, please go ahead and put them in the chat. And we'll also be monitoring them to make sure that they get addressed.
Great. Thank you so much, Debbie, for the very nice introduction. So as Debbie mentioned, I was recently promoted to research scientist, and I'm so happy because of that. And I'm happy too because I am seeing a lot of familiar faces joining the meeting. So I'll go ahead and present on this topic. So I'll be providing an introduction to MOST, that is the Multiphase Optimization Strategy. I'll provide an overview of the different phases with a special focus on what is the main core of this framework, that is the optimization phase, specifically the optimization trials, in particular factorial designs. I'll provide examples of the use of MOST across the different phases of MOST. And this presentation is heavily based on Linda Collins' book on MOST, as well as the training that Debbie mentioned that in which I participated. So MOST is an engineering-inspired framework for optimizing multi-component interventions. And the more simplistic definition here of multi-component interventions are interventions with more than one component. Those multi-component interventions may be aiming maybe a prevention or treatment. They may be targeting health, social, behavioral, or educational outcomes or implementation outcomes. They may consist of behavioral, pharmaceutical, medical, surgical components. The components may be targeting different or multiple levels of influence. And there are several examples in the literature about this kind of multi-component interventions. The intervention components is any part of an intervention that can be separated out for experimental study. So in this plot, I have 5 components of a hypothetical HIV multi-component intervention, and that are motivational interviewing, peer mentoring, text message support, mindfulness meditation, and behavioral skills training. These are 5 components that also, some of them may be can be separated out for experimental study. Like skills, for example, you can have different skills components classified according to the frequency, the intensity, or other characteristics. So anything that you can split out, separate out for experimental study can be considered a component. Here are some examples of intervention components within public health and clinical interventions, within supporting interventions, and within implementation strategies, trying to make this distinction between different types of interventions. So for example, we can have prep for person at risk of HIV infection, but also we can have intervention components that are also educating those at risk of HIV infection on the use of PrEP. So you have the public health intervention that is PrEP, and then you have supporting intervention like education for those at risk. And then you may have an implementation strategy that could be also a component that is training for the providers on PrEP and the HIV medication guidelines, for example. So, and again, each of those things that I was mentioning, they can be further separated out depending on how you envision they will be delivered and developed. So it could be separated out according to the frequency, the dose, the content, anything that can be separated out could be an intervention component. So again, this is about, I'm showing here what the components are of a hypothetical example, the components that I mentioned before. And in this example, we want to develop an intervention to reduce vital load among HIV positive heavy drinkers. And the goal is to choose from a set of components that best reduce vital load. So there are 5 candidate components that I mentioned before. And these 5 are going to, we aim to choose from them to figure it out what to include in a multi-component intervention. That's the goal. So the question is how to build an intervention of these components. So the classic approach, that is the more common one, is to select those candidate components, like those 5 that I was mentioning before that are here: motivational interview, peer mentoring, text, mindful meditation, and training. And then put all of those together in a package and just evaluate that package without previous knowledge about whether each of those ingredients are actually active. On the other hand, the most approach requires to conduct empirically based optimization. That is what I'm going to be talking. That's the main difference in the core of the classical approach versus most approach. That before putting things into a package or a multi-component intervention, you need to first screen those components out. So these are the 3, this flowchart shows the 3 phases of most that are the preparation, the optimization, and the evaluation. And each of these has different activities. In the preparation phase, it focuses on deriving a conceptual model in which the different candidate components are being depicted, and then those are selected, pilot tests are conducted, and also an important thing is to identify an optimization criteria. And I'll be talking about each of these things in the next slides, in particular about the optimization phase. So once the candidates have been identified, the next phase is the optimization, in which those are being tested using an optimization trial. And there are different options like factorial experiment, fractional factorial experiments, smart designs, micro randomized trial, system identification, and others. Then once you conduct an optimization trial, you need to identify the intervention or the intervention components that meets what it was specified a priori as the optimization criterion. Then depending on the results of that, you may, if the optimized intervention is expected to be sufficiently effective, you may want to go ahead and conduct a randomized control trial or the design in which you will be testing the package comprised of those components that were effective or that meet the optimization criterion. But if they are not expected to be sufficiently effective, you need to go back to the preparation and optimization to try to revise or remove and come with a better set or improved set of components before moving forward to evaluate those in a package. And this is according to one of the principle of most, that is the resource management principle, that is to try to make the best and most efficient use of resources when it's obtaining scientific information. So instead of just like in the classical approach, having some candidate components and then just going ahead and test them as a package, one should try to use the resource more efficiently, because the problem with testing them as a package is that if you don't know that all the components are active, or if you know that they interact, then the results that you obtain in the randomized clinical trial of the package, they will not give you all the information you may want to know. You will not know which of the components are driving the effects of that package. If there is no association between the package and your outcomes, you will not know whether there were actually some things that were active and others that weren't, or if there were things that were antagonist. There were some antagonist interactions between components. You will not know that information. So maybe there were some effects, but they are obscured by the combined effect of all the different things that are put in the package. And then the other principle is the continual optimization principle. So even when you get to the evaluation phase, you may want to, after you conduct your trial and find, based on what you find, you may want to further improve that intervention. And sometimes you may want to go back to the preparation phase. So regarding the preparation phase, this is an example of a conceptual model for the hypothetical example that I mentioned before with 5 components. And this is used to depict the relationship between the components, the mediators that they are targeting, and other outcomes like the behavioral outcomes and the distal outcomes, trying to depict all the different main relationships, and also depicting if there are a priori specified effect modifiers. And in this case, we have the 5 intervention components, each of them targeting just one, because they are expected to affect mainly just one of those proximal predictors or mediators. And also we have, in the case of mindfulness meditation, that they may be also moderating the effects of behavioral skills training. So then the first 3 components are expected to act through changing these proximal mediators, which will lead to intentions to reduce alcohol use and intentions to maintain higher levels of art adherence. Those are expected to respectively impact the alcohol use and art adherence, that then they will lead to HIV vital load. So it's all the path of the different from the intervention component to the distal outcomes, and it's kind of showing causal relationship, but it's not necessarily a causal diagram, but it's to have an idea of the things that are being targeted by what, and what the outcomes to be assessed in the intervention. So the other important thing, once the conceptual model has derived and the intervention components, the candidates have been selected and pilot tested, one important activity is to identify the optimization criteria. And there are different options. One option is basically like anything that is active or associated or significant in the optimization trial is going to be included in the multi-component or package intervention. But there could be constraints regarding different things, but let's say regarding the magnitude of the component effects, the implementation cost or time. So the researcher may want to have some constraints or impose some criterion. In this case, like one could be like selecting the most effective interventions that can be implemented for less than certain amount of money, or that they can be completed in less than certain amount of time, or the one that is the most cost effective, or the most cost effective components. So that's another feature of this framework, is focusing on identifying those other aspects and constraints that will help to develop interventions that are more efficient and scalable. Then once those activities have been completed, one can move to the optimization phase in which is basically conducting, as I said before, conducting the optimization trial as the first step. So I'll be talking now a little bit about that kind of trial. So again, these are 5 components of a hypothetical example. And the question is, what kind of optimization trial design to use for developing this optimized multi-component intervention? And what we need to do is experimentation to examine individual intervention components. The objective is to identify those that are more promising. We want to remove those that are underperforming. We want to learn about the magnitude of each of the components' effect, and we want to know whether they are interacting or not, whether the presence of one is, the effect of one is augmented or reduced in the presence of another one. We don't want to compare each combination to a control or try to identify what is the single best combination of these 5 components that I mentioned before. So we want to know what the effects of each of these are and whether they interact or not. So the question is, what kind of optimization trial design to choose in this case? And there could be 3 options. And the first option could be to conduct 5 trials, 5 experiments, 1 for each of those components, and comparing that component versus a control group, or that is basically not receiving the component. So that could be an option. Another option that may be more feasible is to have a study in which we can compare. We have 6 experimental conditions. We have, it's like a 6-arm study in which we have 5 conditions, 1 for each of the components, and then we have a control group. That's another option. And then the third option is to conduct just 1 factorial experiment in which that is a 2 by 5 factorial to the power of 5 factorial experiment that includes 32 experimental conditions. So these are the options, and as you can imagine, the first option, like conducting 5 trials, it doesn't make much sense. But let's see. I'm going to show now a table in which some of the things I was mentioning are being compared between these designs. So we have in this table, we have the 3 different options. I have another column with the number of subjects, the sample size needed to maintain at least 80% power to detect the same effect using these different designs. Then a comparison also of a column indicating the number of experimental conditions and whether the interactions can be or not assessed. So as we can see in this table, with the 5 individual experiments, that will be a lot of work to conduct 5 trials. We also need larger sample size because it's basically 5 times what we need compared with conducting a factorial trial. And the comparative treatment is 3 times the sample size needed as if we were conducting a factorial trial in this example. Basically, this factorial trial with 352 subjects, that the sample size is the same sample size as if we were conducting 1 randomized control trial in which we are just comparing one of the components versus the control. But the factorial is so efficient that we can add more comparisons with the same sample size. So in this case, we can have up to, in this example, 5 components with the same sample size that we will need just to evaluate the effect of one of the components. And also, none of the other 2 designs, A or B, allow for testing interaction between the components. So the factorial experiment for optimization, these are screening experiments where two or more independent variables or factors are systematically manipulated to achieve balance. And this could be complete full designs in which all experimental conditions or combination factors are included. There are also fractional or reduced designs where select experimental conditions are included. So in the next couple of slides, I will be mentioning a little bit more about these two, especially about the full design, and showing you a little bit more about the about option C with the 32 experimental conditions. I'll be showing you also examples of how it looks at factorial with less conditions than that too, and using the same hypothetical example. So this is the notation for two-level complete factorial designs. Two-level means that there are two levels per factor, and then the K in this case tell us what is the number of factors that we have here. So here I have two examples. One that is 2 by 2 factorial, and then I have one that is 2 by 2 by 2 factorial. And that is telling us that the levels are two-factor levels, so they have two categories, yes, no, for example. And then the number of times that 2 is repeated is telling us how many factors are there. And if we multiply that, like in the last column I have, we get the total number of experimental conditions. So a 2 by 2 have 4, and 2 by 2 by 2 have 8 experimental conditions. And those experimental conditions are the combinations of the factors that we are assessing. And I'm calling them factors now. So I want to clarify what is the difference between factors versus intervention components. A factor is an independent variable with different levels. A factor, like in these two examples in the table, one factor could be text reminder, another one could be reminder in general. The first factor, text reminder, is basically presence versus absence. And the example is text 2 times per day versus no text. And this factor only contains one component, that is text reminder. In the bottom row, the factor reminder has levels that are different. These levels are treatment alternatives. In this case, is text reminder and phone reminder. So the same text reminder that we have before is one of the levels, but then the other level is a phone call reminder. So we have a factor that is a variable in the model that has two different levels, each representing different components. So that's the difference in this case. Something to clarify is that the control is different in randomized control trial and the factorial experiment. The control condition 1 in this case, like the condition that is well, this table is showing us the example of the factorial with only three components, 8 experimental conditions, and the experimental condition number 1 is the one that has in which the participants are not going to receive any of the components, any of the interventions. And one may think that is the reference category or the control group. But in the case of factorial designs, that is not the control group. Each factor has its own control group. So in the right side, I'm showing the same table than before, but I have the rows in different shades of gray to show what is being compared with what. So the main effect of motivational interviewing is the mean conditions of 5 to 8, that is yes motivational interviewing versus the mean conditions of 1 to 4 that is no motivational interviewing. And then the same for peer. For the peer component, the mean of conditions 3, 4, 7, and 8 that are shaded in darker gray are being compared versus the mean of conditions 1, 2, 5, and 6. And the same for text. Different conditions are being grouped and compared. And that is why each factor has its own control. And this can be analyzed using ANOVA or using a regression model in which, like in this case, the main effects there, in this case, with only 3 factors, there will be 3 terms, one for each of the main effects, and then you will have 4 interaction terms, 3 interaction terms that are two-way interactions between each of those 3 terms, and then you will have a higher order interaction term representing the interaction between the 3 components, the 3 factors. Something important in factorial designs is the balance property. Each level of each factors appears the same number of times. As we saw before, when looking to see what was the control or the comparison group, we can see that there were equal number of levels for each factor. We were comparing 4 experimental conditions versus other 4 experimental conditions. Another thing related to the balance property is that every condition has the same number of subjects. Like in this table, there are 44 in each of these experimental condition in each of this. And small variability is okay, but unbalanced data can be also analyzed using general linear models. And also, designs can be balanced even if not all the possible combinations are included. And that's the case for fractional factorial designs. Balance is important because it ensures that estimates are uncorrelated, assuming effect coding is used. And this is an example of effect coding for a variable with 2 levels like text, in which effect coding represented by a -1 for the no category and 1 for the yes category. And in this case, I'm compare that with dummy coding, in which is 1 and 0 are being used instead. And unbalance may cause loss of power. So that is why it's important to maintain balance. This slide summarizes the topic of sample size and power for factorial experiments. These need to be calculated based on the main effects, and you need to choose what the smallest expected effect size. So you choose the smallest for any of the components, and if the study is able to detect that small difference, if other components have expected larger effects, they will not be issuing detecting those as well. So you power for the smallest expected effect size. These studies often require many fewer subjects than other designs, as I was showing the table before. You can have very small per condition, and basically in each of these experimental conditions, like before, there were 8 in the example that I show, and each of those rows has 44 subjects, and I'll be showing you in a minute how those can be split if we are adding more factors. But the thing is that even when we do that, the study will still be well powered. So it is often possible to add 1 or more factors and maintain the same power without increasing the n. And this is possible if the factor that is being added had expected effect size larger than the one that the smallest one for which the sample size was calculated. And you can get an additional factor for free, but not an additional level. So if you want to have a component or factor that has 3 levels, then the N will be needed to increase. And there is software. There are these SAS and R macros that can be used to calculate the power sample size for factorial trials. So here is the example of adding a factor. Again, I have the table here where in the example in which there are in the left, in the example in which there are only 3 out of the 5 components. So there are only 3, and we can see that there are 8 experimental conditions, and the N is 44 for each of those. It's a total of 352 total sample. And in this example, we add in a factor that is mindfulness meditation. And by adding the factor, what is happening is that the number of conditions has doubled. And the sample size per condition is now half of what it was before. But the total sample size is the same. So this is not affecting the sample size again. Now, in the left side, I have the example with 4 factors. And in the right side, I have the example with 5 factors. So I'm adding 1 more factor. So again, the number of experimental conditions is doubling. Now, instead of 16, we have 32. And the N per condition is half of what it was before. So it's getting smaller. Now it's 11, but it's still enough because the total is still 352, the total sample size of the whole study. But if 32 experimental conditions is too much to handle in a given research setting, sometimes if these experimental conditions are, someone want to randomize them on the cluster level, it means that you may need to have, for example, if 1 experimental condition for each cluster, and maybe if the cluster is a clinic, you may not have 32 clinics, but maybe you have 16. So if 32 is too much, but 16 will be manageable, you can, option A is drop what you just added and go back to less components and just do it with 4. Then that will be manageable. But then you'll not have information about the effect of that other candidate component. So you can drop skills in this case. The other option is to conduct a fractional design. So you will not be removing the factor, but you will be removing certain combinations. And in this case, it's a half design in which you are going back to have only half of those conditions, 16 conditions. You will be still able to identify the main effects of those 5 factors. However, only lower level interactions will be, you will only be able to assess the lower order interactions, not those interactions that include all the 5 components interacting together or 4 of them. But the main thing that, as I was saying, is that you will be able to know what the effects of the 5, the main effects of those 5 components are. So once the optimization trial has been completed, you need to identify the intervention that meets the optimization criterion that it was specified before. That again, it could be all active components. Anything that is active is going to be included in the multi-component intervention. It could be, there could be some constraints regarding the cost, the time, the cost effectiveness. So then if the optimization, the optimized intervention is expected to be sufficiently effective, then you go ahead and evaluate that package, right? And for that option, the main option in terms of what is considered gold standard is to do a randomized controlled trial, and this could be a cluster randomized trial, but also there are other designs that can be used, quasi-experimental designs, and other alternative randomized designs, and even you can do another factorial design or another designs that will be used also for optimization. You can even do effectiveness implementation hybrid designs and also adding mixed methods to that. So now I'm going to show you an example of an intervention developed, optimized, and evaluated using this approach. So It Matters is the name of this intervention, and it's an online intervention that targets the intersection of alcohol use and sexual behaviors with the goal of reducing a distal outcome that is sexually transmitted infections among college students. And these are the 3 publications in which the investigator presented the results for each of the phases, of the 3 phases. So in the preparation phase, they identify different components. They identify a general information component that is a constant component that is going to be delivered for everybody. And they also identify 5 experimental components that are named after the determinant that they are targeting. They have descriptive norms, injective norms, outcome expectancies, perceived benefits of protective behavioral strategies, and self-efficacy. So they are, again, these components are named after their targets. And in this table, we can see what the purpose of each of those are and what kind of things they are using as what they call strategies here. That is basically what are the methods or the applications they are using for each of these components. And I'm not going to go through all of this, but this is an online intervention that presents information online for the students, and that information includes text, includes videos, graphs, simulations, providing content on all the different components. And each of these components and the outcomes of each of these components are the proximal outcomes that are basically the change in those determinants that they are targeting. Here is the conceptual model that they elaborated, in which they depict the relationship between what the 5 components are. Is some of the same information. In the left side, we have pretty much the same information that it was in the table before, with the 5 candidate components plus the basic general information. And we have the proximal mediators or proximal targets of those components that are expected to influence alcohol use and the use of protective behavioral strategies. That is expected to lead to changes in the alcohol-related sexual risk behavior. So they are targeting these outcomes, the alcohol use and the sexual behavior outcome. And they are trying to target this intersection. Within the distal outcome, again, the health outcome is decreasing sexually transmitted infections. So this, in the optimization phase, since they have 5 components that they want to test, and they have information that is delivered to everybody, they are using a design like the one we saw before, in which they have 5 experimental factors, and then they have information that is delivered to everybody. So they are not assessing the effect of information. It's just they want to know what are the individual effects of each of those 5 factors mentioned before. And their optimization criteria specifies that all the active components, those that are significant, are going to be included. So that's the only criteria. They are not imposing any other constraints. And something interesting here is that they actually, after moving from the preparation phase to the optimization phase, they actually did an iterative optimization. They conduct 2 optimization trials. They conduct one optimization trial in which they found, that is the one in the top, they found that only the component called injunctive norms had a significant effect. And they didn't find any interaction between the components. So then they conducted focus groups and interviews. And based on that feedback, they implement 3 changes. They changed the narrator, shortened the length of the intervention, and made measures more concise. Measures basically, the way they were assessing the outcomes, the scales were improved. So in the optimization trial 2, that is the same design, the same components, the same outcomes, now it's an improved set of candidate components. They were able to, and in this table, what is being shown, as you may have noticed, is the p-values. So in this table, they found that not just injunctive norms, but also descriptive norms, descriptive norms component was associated with their specific proximal outcome. And none of the other components were significantly associated with their outcomes. So they decided to select those 2 norms components and include them in a package or a multi-component intervention. So they moved to the evaluation phase. And in the evaluation phase, they have 2 goals. One is to evaluate that package that comprises of information that was delivered to everybody, and the other 2 descriptive norms and injunctive norms that were selected, those 2 components, right? But they also wanted to see if they could add another component after they have already tested those others. And this is because the participant universities requested them to include a sexual violence prevention component that covers the 3 things that are listed below there. So they did since there are their 2 goals, some of you may already imagine what kind of design they use. So they want to test 2 things. To evaluate their It Matters intervention, the package that they just developed, but also they want to conduct optimization. So what they do is they conduct, again, a factorial design. But this is a hybrid factorial design in which they are evaluating the effects of the optimized intervention and at the same time trying to test if another component can be added. So they have a 2x2 factorial, meaning they have 4 conditions, A, B, C, D in this table that are basically the combination of the levels of the factor and the optimization factor. Basically, it matters whether they receive the It Matters interventions, yes or no, and whether the candidate component was provided, sexual violence prevention. So they did that's trying to be efficient and not waiting to separately optimize that component. They did both things at the same time with a 2x2 factorial. And these are the results for the optimization results. And in this table, what they are showing are the main effects and the p-values. And these are coded in a way that a positive coefficient tell us whether there is a expected desired effect. And the outcomes here are 5 self-efficacy outcomes. Those are proximal outcomes of the candidate component, and 3 protective behavioral strategies outcomes. And they measure this with the scales. And they found that this component was significantly associated with 3 out of 5 of those self-efficacy outcomes, and with all the protective behavior strategies. However, they only found this association at the immediate follow-up. At the 60-day follow-up after the intervention was delivered, the results disappeared. They didn't show up anymore for any of those And also any the main effects of it matters in these proximal outcomes of the component were not significant. That was expected so why? Because these the other components are not targeting these outcomes, and there was no interaction between the optimized intervention and the candidate component. Then in the evaluation, these are the results regarding the evaluation, and in this case, they have different outcomes. Again, they have the proximal outcomes that are basically what I showed you before: descriptive norms, injunctive norms. They are evaluating those with linear regression. They evaluated 2 different time points: immediate follow-up, 60-day follow-up. Then they have behavioral outcomes, individual and intersection behavioral outcomes, and they evaluated those using for binge drinking using negative binomial regression, for condom use logistic regression. So it depended on the kind of outcome they use different regression methods, but these were only evaluated at the 60-day follow-up. So what they found regarding the main effect of it matters is that it was significantly associated with descriptive norms and injunctive norms as expected, that are the proximal outcomes at both immediate follow-up and 60-day follow-up. However, the intervention was only associated with the binge drinking. So it was not associated with other individual outcomes or intersectional outcomes. And they also explored with this design, they were able to explore the main effect of SBP also in these behavioral outcomes, and they didn't find any significant association except for a underside effect on the proximal outcomes. So they concluded that it matters was effective because it changed the proximal outcomes and behavioral ranking. However, they need to make some modifications, target a population at higher risk to see if there is an effect in other more distal outcomes and the intersection outcomes. And now this study also provided preliminary evidence of the effects of the proximal outcomes for this component candidate intervention, which the investigators said that they will further optimize, revise, and retest before considering including the MARIS intervention. So they are still trying to improve both and trying to improve the design in terms of the population that is going to be targeted and whether boosters are needed and maybe a longer follow-up to see effects in distal outcomes. So that was my last slide, and these are my overall conclusions. It's just at most is a framework for developing optimized multi-component interventions, including implementation strategies. So any kind of multi-component intervention is useful for building interventions using empirical base is the main focus, that empirical based optimization. And there are other things that can be added to that optimization based on other designs, and framework can be combined with other things too. Multi-component interventions that are designed with most could be more effective, economical, efficient, and scalable, given that you are screening what it works and what it doesn't work, and also you are also identifying a project criteria to know in terms of cost or time, and that will be useful for knowing how in terms of how economical and scalable the intervention will be. That was the end of the present. That is the end of the presentation. Thank you so much. So there was
Thank you. Right? Thank you, Raul. That was it was clear and very detailed. And your example answered some of my questions. But I would, as you noted, we do have one question in the chat. I don't know if Vilma wants to speak up and share her question.
Yeah, let me go back to the slide and maybe see the.
Or you can.
Yeah. So the question is, the question is if interaction among the different components of a complex intervention is key characteristics of this multi-components, what would be the best way to interpret this from the most strategy base? Yeah, so yeah, in the most strategy, you need is the optimization phase, what I was describing, what is needed to know which part of the which components are the ones that are active. So you want to do that optimization trial to test each of those components and know whether they interact or not. If you don't have that information and conduct a regular trial in which you come. Oh, thank you, Vilma. So if you don't if you can do a regular trial in which you test the package, you will not be able to know to have that information. So yes, in some way, both can be basis for selecting components, because you want to focus on the main effect, whether they have an effect or not. But also, if you find that certain components are doing things better, augmenting the effect of others, that's great, right? Because that will make your intervention more effective. But you find that there are some antagonist interactions, you may want to figure out which component to select or what to do to deal with that before moving to the next phase. So affects the selection of components again, not having that information. And
So,
limits.
Okay, Raul, can I add something to that?
Yeah.
I mean, I feel like what Vilma's asking about is exactly the reason why we want to use most and the factorial design. And that once in the first two stages, once, you know, a large number of components are weeded down to a smaller number, in the factorial design and the full factorial, you have power to assess all of these interactions because the design has been balanced in that way. And if there's reason to believe that maybe 3 or 4 level interactions might not be important, a fractional factorial design can be used. But it's a much more, it's much better suited for assessing and evaluating multi-level, multi-component studies where we think there might be synergies and interactions. Don't you agree, Raul?
That's correct. And especially when you want to know whether they have an effect, sometimes there is not enough evidence or the interventions have been adapted. So if these are newly developed or adapted intervention components, you may want to test them before moving to the evaluation phase.
So we know we're right at the time. I think Raul might be able to take 1 or 2 other questions, but if you need to go, please do feel free to go. Raul, what my question, oh, go ahead. I heard someone else.
No, I don't think so, right? So,
okay.
Yeah, what is your question? Sorry.
So one of my questions is, in operationalizing this, the example that you chose was an internet-based people and then assign them to the different groups. When you're doing this in physical locations, is it more common to randomize within a single site or across multiple sites? And then how does that, how does a multi-site situation impact the sample size and all of the other calculations?
Yeah, that's a very good question, because in this case was individual people that were randomized, and in some cases it makes more sense to deliver interventions to the individual but assigned to certain clusters of clinics or settings. So what is affected there in terms of sample size, you need to consider the clustering, but also logistically, like in terms of conducting the study, you may have a limited number of settings. So if you have many combinations, you may not be able to assign, or experimental conditions, you may not be able to assign each of those settings to each of those conditions. So you may, if it's easier to do it at the cluster level, that you have certain number of clusters, you may need to consider less or just the exact amount of components that can be used for that setting. So there could be limitations so that you cannot do, like in the example, you cannot have 32 experimental conditions because it's too complicated to do that with individuals. And if you don't have even that number of clusters, it may be very challenging. So you need to figure out what part to modify, but the sample size can be still very efficient compared with, because it's basically compared with just testing one effect for the same sample size versus having the opportunity to test for multiple different effects. So that's one of the main advantages.
So what I'm hearing is just that there's some pragmatic concerns that need to be addressed if you're considering multiple sites that may impact how many factorial levels you can do and so on.
Exactly. And you need to, and that affects the design and the analysis when you need to take into account certain clustering.
Great. Well, thank you, Raul. Thank you to all of you for joining us. And we will have a recording and a link available soon. And look to seeing you for Laurent's presentation in November. Thank you all.
Thank you so much, everybody. Bye-bye.